rather than pericardium and the myocardium. So in the valve there is a valvulitis. Acute phase there is a valvulitis or inflammation at the site of valve. Then there is a chronically there start fibrosis and calcification. Then these goes stenosis of the heart wall, so fish mouth wall. So first it start as a form of valvulitis. At that time there is a regurgitant lesion in the valve. Usually involved valve is a mitral valve. So mitral valve leads to mitral regurgitation. So if we see that in any MCQ questions in the examination, acute rheumatic fever, first lesion is MR, not MS. It leads to fibrosis and then calcification and then stenosis of the valve, fish mouth valve. That is stenotic lesion. So it's called MS, mitral stenosis. Thick fused chordae. Now Sydenham's chorea. It's an involuntary movement, choreoathetoid movement, involving primarily of the face, tongue and upper extremities. It can involve the lower extremities, but usually face, tongue and upper extremities involved. And choreoathetoid movement. Sole manifestation 50% cases, no other sign may be seen of the rheumatic fever like subcutaneous nodule, skin, joints and the heart involvement, but only the Sydenham's chorea, but usually seen in the children's. Less than 15 years of age, the presentation of acute rheumatic fever, 40 to 50% cases may be only the symptoms of the Sydenham's chorea. Girls more affected, rarely in the adults. Least common but most diagnostic manifestation of the rheumatic fever. It is only seen in the less than 3% cases, but it is the surest sign of the rheumatic fever. Arrhythmia marginatum. It's a rapidly enlarging macules that assume the shape of rings or crescent with clear center. They may be raised, confluent and either transient or they may be persistent. Like this, like allergic reactions. This is only the macule formation, but they have a circumscribes. They have a rings formation. Subcutaneous nodules, uncommon except in children, usually seen in children. Small, less than 2 cm in diameter, firm, non-tender. Very small, firm in consistency and non-tender. Attached to fascia, they are not mobile. Tendon sheath over bony prominence, persist for days or weeks, or may be seen in the recurrence, indistinguishable from rheumatoid nodules, seen in the rheumatoid arthritis. So after this, we plan for some investigation. Once patient comes to you with these phenomena, like Sydenham's chorea, arthralgia, subcutaneous nodules, skin rashes, or the heart involvement in the regurgitation or the stenotic wall, valvulitis or the stenotic wall. Usually in the heart, there is the initial symptom is only fatigue. After a few distance, children or adults they have a fatigueness or sometimes palpitation. These are the two symptoms only in the early phase. So now we have patients usually have history of throat infection. If we inquire for the previous history, there is definitely a history of the recurrent throat infection. So once we have suspected rheumatic fever, advise some lab. Lab shows anemia, usually hemoglobin lower side. Leukocytosis may be or may not be seen. Usually mild increase in the TLC, ESR is raised, CRP is raised, that is acute phase reactant only. ESLO titer, anti-streptolysin antibody titer, that is increase more than 200 is positive. Anti-DNS we test, and then throat culture. If patient coming to you have throat infection, advise for swab throat culture. ECG, if patient have a fatigueness, advise ECG. ECG initially shows only prolonged PR interval. Sometimes second or third degree block, ST depression or TB invasion rarely seen, but prolonged PR interval is usually seen in the cases of acute rheumatic fever. 2D echo, if we are suspecting there is a cardiac involvement, the valve edema due to the inflammation, mitral regurgitation, because there is a valvulitis in the initial stage, so there is a regurgitant flow from left atria to left ventricle to left atria. LA-LV dilation, if there is a chronic phase, LV get dilated. L is dilated in pericardial effusion may be seen in the form of pericarditis, and decreased contractility if there is a heart failure. So rheumatic fever is mainly the clinical suspicion. So clinical diagnosis is important. No single diagnostic sign or specific test is available, but there is a whole labs and clinical and some imagings. So diagnosis for this, there is some criteria is adopted. There is a modified Jones criteria. What this is, some there is a major manifestation, some minor manifestation, and some supporting evidences. And there is a major manifestation. There is a carditis, arthritis, chorea, skin erythema marginatum, and subcutaneous nodules. All the 5 features are the major manifestations. Minor, in the clinically, there is a fever, mild to moderate grade fever, joint pain, heart disease, or the previous heart disease or previous fever, rheumatic fever. In the labs, there is acute phase reactant like ESR and CRP has increased, some leukocyte count is increased, and ECG shows PR interval is prolonged. In the supporting evidence, ASLO titer, anti-DNA is B positive, and throat culture is positive. So all the 3 gives the idea of the diagnostic for the Jones criteria. So presence of 2 major criteria, or one major criteria and 2 minor criteria, indicate there is a high probability of acute rheumatic fever if supported by the evidence of the infection by the throat culture or ASLO titer or anti-DNA is positive. So we account for the major and minor manifestation. 2 major or 1 major and 2 minor manifestation indicate there is a high probability of the infection. So we advise for the throat culture or the antibody test. Chorea alone, if other causes have been excluded, insidious or late onset carditis with no other explanation, and patient with documented RSD or prior rheumatic fever or 1 major criteria or the fever of arthralgia or high CRP suggest there may be a recurrence. So these are the exception of the Jones criteria. Now we have to differentiate from the other with the juvenile rheumatoid arthritis is similar feature. Septic arthritis, Kawasaki disease usually seen in the children's, myocarditis, scarlet fever, and some leukemias. These have a fever, myalgia, arthralgia, scarlet fever, some myocarditis due to the other causes, and the Kawasaki disease, septic arthritis, and juvenile type of rheumatoid arthritis. In the juvenile rheumatoid arthritis, in their cases also there is a fever and myalgia and arthralgia. How we treat? So treatment, there is a step 1, there is a primary prevention or some eradication of streptococcal infection. Step 2, there is an anti-inflammatory treatment should be given in the form of ecosprin or aspirin, and sometimes you can use the steroid. Step 3, there is a supportive management and management of some complications. And then step 4, there is a secondary prevention of recurrence. So in the step 1, there is a primary prevention or eradication of streptococcal infection by the antibiotics, anti-inflammatory, supportive management, and secondary prevention. So step 1, there is a primary prevention of the rheumatic fever or streptococcal infection if patient have a tonsillitis or tonsilopharyngitis, because these may convert into the carditis or some other clinical features, so we have to prevent it. So benzathine penicillin is given. This should be given 1.2 lakhs unit for patient if they are more than 27 kilograms, or if they less than 27 kilograms, there is a 60,000 international unit. This is a mode of deep intramuscular injections, and duration is once in the quarterly. Penicillin V, there is children's, it can be given with the oral form, 250 milligram 2-3 times a daily for 10 days. For individual allergic to penicillin can be used erythromycin, but nowadays erythromycin is obsolete, so azithromycin or clarithromycin should be given. It causes cholestatic jaundice. Ethosuxanate can be given if patient is not tolerable. So agents, penicillin in the oral form, duration is 10 days, and penicillin B or pentate tablets. In the penicillin B, there is a 50 milligram per kilogram once daily. Maximum should be a 1 gram orally for 10 days. Benzathine penicillin, it should be given as 60,000 or 1.2 intramuscularly once. Or for individual allergic, there is a penicillin, can be given cephalosporin, cefadroxil. Usually safe drug in children is a cefadroxil. Then clindamycin can be given, azithromycin and clarithromycin is used in nowadays. Step 3, there is a supportive management or the management and complications. So patient advised to bed rest at the acute phase, and treatment of if patient have a congestive heart failure, so accordingly we have to use some diuretics, or LV failure is there, so we can use the digitalis. Treatment of chorea is only the haloperidol. Diazepam is not used nowadays, and the rest to joints and the supportive splinting can be used. Sometimes patient have a excessive pain on. Secondary prevention of rheumatic fever. Benzathine penicillin should be given every 4 weeks intramuscularly, or in oral form penicillin V can be given for long days. Sulfadizine usually not used nowadays. Erythromycin is not used, but azithromycin can be given in the lower dose, or roxithromycin is used nowadays for the long term. If patient have pain, aspirate is a joint pain, aspirin should be used. Duration of secondary rheumatic fever prophylaxis is categorized. Rheumatic fever with carditis and the persistent residual heart disease or persistent valvular disease at least 10 years. Since last episode, and at least until age of 40 years, whichever is longer. So usually patients comes in the early phase, so we can use up to the 10 years. Rheumatic fever with carditis but no residual disease, 10 year or well into the adulthood. So rheumatic fever with carditis 5 year, without carditis only the 5 year is, or the 21 years. So 5 to 10 years is the duration for which we have to use benzathine penicillin for the secondary prevention. 10 years if the heart disease is there, without heart disease the 5 years. Now the prognosis, rheumatic fever can recur when the individual experiences new type of the streptococcal infection in the other serotypes. If patient not on prophylactic medicines, so prophylaxis for secondary prevention is mandatory. Good prognosis for the older age, if no carditis during the initial attacks, and bad prognosis for the younger children and those having Carditis or the valve involvement at the time of initial attack. So initially patient have a carditis in the childhood age, have a bad prognosis, and they have to go for the mitral valve replacement or the some other heart failure management also. But if the adult phase and then having the cardiac involvement, they will have a good prognosis. So rheumatic heart disease result from single or repeated attack of the rheumatic fever, rigidity and deformity of the valves resulting in stenosis or incompetency of the valve. So mitral valve alone in more than 50% cases involved, and sometimes 25% cases is mitral and aortic, and rarely pulmonary valve is involved. Pure aortic is also uncommon. History of rheumatic fever obtained in the 60%. So history is important. That gives you a clue to the rheumatic fever or rheumatic carditis if patient have a throat infections. Should receive prophylactic penicillin monthly and preceding dental extraction, urology and surgical procedure to prevent endocarditis. They have more chances to urological infections or the surgical procedure at the time of surgical procedure. So prophylaxis should always be given such type of patient.